For this morning's presentation, I was asked to speak about hard and soft tissue grafting principles, hard and soft tissue considerations for implant dentistry. Because a lot of what we do in implant dentistry is not so straightforward. And I'm sure you've noticed that the past few days with the previous presentations. Implant dentistry is a very involved discipline. It's not very easy discipline to master. I don't know if we can certainly master implant dentistry because we're always learning. There's always new ideas, new techniques, and new materials that keep coming out on the market. And it's a good thing because it helps us to be a better clinician, and then it helps us to be able to provide better services for our patients. And so we learn from each other, we learn from our experiences, and we like to take these opportunities to be able to share what we've gone through. And as Dr. Clutty mentioned, some of the things that we learn the most from is our mistakes and our failures. And so that's where we gain a lot of education. So today we want to kind of go over some ideas and principles of hard and soft tissue grafting, understanding how do we simplify some of these procedures. There are ways that we can simplify some of the grafting procedures. And if we can utilize those concepts and if we can utilize those techniques, it's going to make your job a lot easier, and it's going to give the patient a better experience. And so we'll look at different clinical situations because at the end of the day, we're clinicians, we're treating patients. And so we want to use the best materials, we want to use the best techniques, we want to have the best outcomes for all of our cases. And so we'll look at some of the cases in terms of the indications and how to maximize the potential for those cases. So when we look at hard and soft tissue grafting, we have to understand why we're performing those procedures. What's the reason for performing grafting procedures? Understanding when do we have to graft? Or is it necessary to graft? Maybe it's not so necessary. So we'll look at some issues regarding when we graft, the timing of grafting, and what kind of materials do we use? There are many, many different materials in the market. Many materials, many companies, and so I'll just share my experience with what I use and what I think has been the best materials to use for my patients. And so we'll look at the timing, how long do we wait. So there are strategies that we can employ. There are strategies that we can use to help us give us that predictability. And so we have to understand when we do grafting, you may hear lectures on just hard tissue grafting, bone grafting. It's very important. You may hear lectures on just soft tissue grafting, which is also important. But many times when we look at hard and soft tissue augmentation grafting procedures, a lot of times they really have to go hand in hand. Not so much as two separate entities, but many times, more often than not, we have to perform both hard and soft tissue grafting for our patients. Because if you're looking at this picture, you can see, when you look at it from the occlusal view and you look down, there's certainly a large defect there, right? You have that indentation, we have this concavity here, so you can certainly appreciate that there's not enough bone there. That's what it looks like. And it's not even just a bone, just a tissue. If we look at it, it's going to tell us that it's probably a mucogingival defect, right? Soft tissue defect there. So we want to understand some of the principles. Looking at it from a colorful view, from a photograph, you can see the defect there. And it's a pretty large defect. And you would ask yourself, is there or is there no bone? And just by looking clinically, you may assume that there's no bone, right? So unless we have more information, we talked yesterday about having information, gathering data, getting all the information that's going to allow us to plan our cases much better. And so just looking at this case, it looks like there's a large defect here where there's probably not enough bone. And in many cases, even the soft tissue, if you look here, it looks like almost a soft tissue defect as well. Okay? How about this case? If you look at this case and I were to ask you, do you think there's bone? How many of you would say yes? How many of you would say no? It's hard to tell unless we have more information, but if there's a little concavity here, you would think that there's probably maybe not enough bone, right? So this is some of the issues that we deal with. But first thing we want to do is just kind of clinically evaluate our cases. something like this, we want to look at the soft tissue, right? The soft tissue, the gingiva, and ask ourselves, is there enough soft tissue? Just looking clinically, yes, it looks like there's an adequate amount of soft tissue. Good keratinized tissue. That's what we're looking for. And so we would classify this as, do we have the biotype? What type of biotype is present? Okay. Looking at a patient from an aesthetic point of view, we need to evaluate the smile line. Okay? Looking at the patient's smile, does this patient have a high smile line, low smile line? Because again, as we deal with cases in the anterior aesthetic zone, we have to evaluate the smile as one of the first criteria to determine how we're going to manage that case from an aesthetics point of view. So the aesthetics may really be the driving force between all of our anterior cases. And so we can evaluate our cases, which we have to evaluate from a hard tissue, soft tissue, and an aesthetic point of view. And so we know these terms. These are terms that have been quoted many, many times from practicing clinicians. It says that the bone sets the tone, but the tissue is the issue. Right? Maurice Lama, right? He used to say this all the time. The bone sets the tone, but the tissue is the issue. And if we think about that, there's a lot of value in that quotation. Right? The bone's going to set the tone, meaning that's going to give us the foundation. Right? So we have the foundation, but the issue, the real issue is really the tissue, right? The soft tissue. And so the soft tissue is going to be the ultimate factor in terms of the aesthetics, right? Supporting the final restoration. So the tissue is really the issue. And if we go one step further, there's another quote, another saying by Craig Mish. He goes, the bone sets the tone, but the tissue is the issue, but the buccal plate sets the fate. Right? So if we think about that, the buccal plate sets the fate. And I showed you yesterday, right, with the buccal bone, when we do immediates, that buccal bone thickness is how thick, or rather, how thin is that bone? It's actually pretty thin, less than 1 millimeter thick. So that buccal plate, especially the anterior aesthetic zone, when we're dealing with the aesthetics, is pretty critical. So the bone sets the tone, that gives us the foundation to be able to place implants. That's going to support the soft tissue, but the tissue is the issue because of the aesthetics. But really, it's the buccal plate that sets the fate, because if that buccal plate is not there, then everything is deficient. And so that means then we need to do some type of augmentation to be able to rebuild, to help us get us to that point of getting to the final aesthetic outcome. And so we have to understand that we want to always set ourselves up for success. Every case that we do, we want to make sure that whatever we do, whether it's hard tissue grafting, soft tissue grafting, we want to make sure that we can always set ourselves up for success. That's what we all want for our patients. That's what you want, that's what I want, that's what the patient wants. And so understanding we want to set ourselves up for success. But with everything we do, every procedure that we do, there's going to be success, right? There's going to be failure, which you've seen a few of my cases, but there's always risk involved. There's always risk involved with every case that we do. No matter how simple we think each case can be, there's always a risk. And sometimes those risks are out of our control because it may be patient dependent, because you can give them hygiene instructions, you can give them post-operative instructions, but if they don't follow the rules and they don't follow your suggestions, then it may not work. You could have the best bone, you could have the best implant, you just did the best surgery, but if the patients are not compliant, meaning if the patients don't brush and take care of the area, if the patients don't avoid chewing on that side, then you may have more risk involved with that case. Okay, so every case that we do, that wasn't me, right? So every case that we do, there's always some risk involved. And so our goal, our job as a clinician, is to minimize that risk. Okay, I can do it. Thank you. So we want to minimize that risk. Even with presentations, there's risk involved. Right? There's always risk with everything we do, not just implant dentistry. Okay? When you walk the streets, there's a risk. You're risking your life. In New York City, the driving is not like the driving here in Vietnam. Right? There's rules in the United States where you stay in the lane, you're gonna signal if you want to cross the lane. But it's a new experience for some of us here in Vietnam with trying to cross the street. So we've gotten better. So we're still here. So when we look at success for our cases, again, as I mentioned, it's really not about just the hard tissue and soft tissue. Both components really have to be considered, because ultimately when we look at our cases, especially the anterior implants, the driving force is going to be the aesthetics. Right? The driving force really is going to be the aesthetics of that case. That single anterior tooth, the missing lateral incisor, the missing central incisor. How do we get to a point that's going to give us the best foundation, the bony foundation? Do we need to do soft tissue grafting to give us the best tissue foundation? Right? If the bone's not there, many times we know what happens to the tissue. Where does the tissue go? Right? It follows the bone. And when that happens, there's consequences, because ultimately it's the aesthetics that gets compromised. And so success really is dependent upon having all the parameters in place. When we look at the aesthetics, we have to look at the amount of bone that's present. How much bone do we have? Right? Do we have adequate bone? And it's not even just the amount of thickness of bone. How much volume of height do we have? Do we have adequate height? Because we saw yesterday, if we don't have the adequate height, then that compromises the aesthetics because of where the margins of the implants may be. So how much bone do we have? Tissue, how does that play a role in the aesthetics of the case? It plays a huge role. As you see through in the presentation, peri-implant soft tissue. And then the final form and shape of the restoration. How do you make the crown to match the shape of the adjacent tooth? Right? How do you give it the contours? How do you give it the shape? Right? How do you give it the color to match the tooth next to it? So the shape, the form, and ultimately the understanding the implant position. So when we look at the aesthetics, we have to understand, again, as we mentioned over and over again, it has to be prosthetically driven. Prosthetically driven, crown down implant dentistry. And so even though I'm talking about hard tissue, even though I'm talking about soft tissue grafting today, it still depends. It's going to be dependent upon the final prosthetic outcome, the final crown. And so we want to make sure that we can have all parameters in place, taking the risks, knowing that we may get a success, we may not get success, but we want to have all the principles in place to help us get to that point. So if you look at this case, you can see there's some soft tissue recession. Now in 2008, Cyril Evans published an article. He says the aesthetic outcomes of immediate implant placements. So we talked yesterday about immediate implant placement. One of the biggest compromises that gingival recession increases in patients with a thinner biotype. Okay, so think about that. Thin biotype. And you guys know how to measure biotype? So when you look at your tissue, you have to determine whether or not you have a thick or thin biotype. For patients who have a thinner biotype, thinner tissue, right, there's more risk of recession in those types of patients. So the thinner the tissue that the patient has, the more risk involved. If there's risk of recession, is that going to lead to success or is that going to lead to failure? More often it's going to lead to a failure of that case. Not necessarily implant not necessarily a implant or hard tissue failure, but a soft tissue aesthetic failure. So gingival recession will increase in patients with a thinner biotype. Gingival recession is one of the most common problems that we see with anterior implants. And so that's why I'll tell you, anterior implants is probably one of the hardest, most challenging cases that we can do for our patients, because of the most common complication associated with thinner tissue. And so if we have thin tissue, you have to be thinking, what do I need to do to the thin tissue to minimize some of those complications? That means you have to do some type of soft tissue augmentation to thicken the tissue to give it more stability so that you can prevent the recession from happening. And so that means with soft tissue, with thin biotype, then we have to do some type of a procedure to improve the condition or a procedure to prevent this from happening. So in this case, we can see a lot of inflammation. We have some recession that's showing the custom of UCLA gold abutments. Not very aesthetic. Not very aesthetics. What else do you see? You see this, what's called that black triangle. That black triangle is also known as the triangle of death in aesthetic implant dentistry, because patients will always come to you and they'll pull their lip up and Dr. Kim, what's that black triangle? I said, what triangle? I don't see a black triangle. It's this little space there. They all tell you, they all ask you what that space is, right? And so that's the complication. 2018, the terminology phenotype came onto the scene because, the formatting got you. So we used to classify soft tissue as either thick or thin biotype. 2018 at the consensus workshop, they realized that the term biotype is not completely accurate. You cannot just classify tissue as being thick or thin. So we had to change, they changed the terminology from biotype to phenotype. And what that means is the phenotype, the definition of that is the periodontal phenotype is determined by the gingival phenotype, which is the gingival thickness, the keratinized tissue width, and bone morphotype, meaning the thickness of the buccal plate. So that's the new terminology now that we use today. Does the patient have a thick or thin phenotype? What's their phenotype like? Because it's not just about the tissue anymore. It cannot be just about the tissue, because it also has to be dependent upon the bone. More specifically, the thickness of that buccal plate. Because if you have thicker bone, thicker buccal plate, that's what's going to give stability to the tissue. If the bone is thinner, what happens to the bone more often than not over time? The thinner bone will continue to get thinner and thinner, maybe resorb, and you may lose that buccal bone. If you lose the buccal bone, what happens to the tissue? See how everything follows one another? If the buccal bone is thin, the tissue follows and you get recession. And ultimately that's what we see with thin biotype, thin phenotype, we get more recession. And so look at this case. This is a case that I did. Now, when I did this case, this is a 2-unit implant supported bridge. Implant in the lateral incisor, implant in the lateral incisor. I tried to be smart, thinking that it's the lower anteriors. I knew the tissue was going to be thinner. And so what did I do when I did the prosthetics? Can you see what I did? I try to use zirconia ceramic abutments. So we thought that if we use ceramic abutments rather than titanium abutments, that was going to give us a better aesthetic result. It's going to minimize maybe the shadowing or the darkness of the metal. So that's why I used ceramic abutments. That's what you see here. So the margins of the crown, the restoration of the bridge is here. This is a ceramic zirconia abutment, So I thought I was being smart in using zirconia abutments to help improve the aesthetics, because I knew that the tissue was going to be thinner. But ultimately, what happened? I still got some shadowing. So what's this dark shadowing that you see here? The implant. That's the implant that we're seeing. So even though I used zirconia abutments, the tissue, because it's so thin, I started to see the darkness from the titanium of the implants. And so the patient asked me, Dr. Kim, what's this dark area by the gum line? I said, well, your tissue's a little bit thinner. I said, well, I don't like it. It's like, why? Because when you look, you see that dark area. It's like, well, don't do this. Don't pull your lip down. But they always come back and tell you, but I don't like the way it looks. Does it bother you? No. Is it painful? No. Does it swell? No. But it just doesn't look right. And the patient's right. It doesn't look right. And so then, how do we correct that? Not very easy. We can try surgically, but if I try surgically with, say, a connective tissue graft, how predictable is it in terms of, am I going to be able to cover that darkness? It might work, it might not work. There's going to, again, be more risk involved. I may make it worse. And so I'm hesitant to do a soft tissue procedure. How about this case? I saw this case when she came back after I finished the crown. Dr. Kim, what's that little dark area in the middle? What do you see? Again, you're starting to see the titanium from the implant. Why did this happen? So every time I see a complication, I see something that's going on with my cases, I ask myself, what happened to this case? Why did that happen? And I think it's pretty obvious we know why. Because the tissue is thin, because the bone was thin, and so ultimately I started to lose the bone supporting that implant on the facial. I lost that bone there, and I lost the bone, the tissue started to shrink as well. And then ultimately what happened was started to get the aesthetic consequence, aesthetic failure, possibly even maybe in the future, potentially implant failure. So this is going to continue to resorb if we don't do something about it. We have to do some type of procedure to try and correct that deficiency. So again, thin phenotype. We understand now it's not just biotype, it's not just the tissue, but we have to consider both the tissue and the bone. So thin phenotype, meaning thin tissue, and also thin biotype, thin buccal plate. This is what we're looking for. I showed this case yesterday. Right? Look at the thick phenotype that's present. The tissue is very, very thick. That's what's going to give us stability. That's what's going to support the bone. That's what's going to support that final restoration. Having a thicker phenotype, thicker biotype. So that's what you want to see with our patients. And I see this more often today from even my older cases that are coming back, not just in the anterior aesthetic zone, but also in the posterior quadrants. When I first started doing implants, our faculty would tell us, don't worry about the posterior implants. You don't need thick tissue. You don't need keratinized tissue there. And I believe them. Everyone believed them. We thought back then that it wasn't important. But today we know it's critically important to have thicker tissue, thicker keratinized tissue supporting our implants. So even today in the posterior quadrants, if there's thinner phenotype, thinner biotype, we always advise the patients that we need to do a soft tissue procedure to thicken the tissue, because that's going to support the final prosthetics, the final outcome of that restorative case. Thick phenotype, that's what we're looking for. See, in the posterior, in spite of the implant being maybe placed a little too buccal, right? You can critique my implant, it's a little too buccal. Look at where the central fossa is of the premolar. Look at where the central fossa is of the molar, right? The implant, the fixture should be somewhere along that central fossa line, right in this area. So this is probably a little too buccal. But the tissue looks pretty healthy. The tissue looks pretty stable, but it looks actually a little thinner on the facial, right? Look at the tissue. After we put the abutment in, look at the thickness of that keratinized tissue. I have keratinized tissue, but a little bit thinner. But it's healthy and stable. A little thinner, but wider band of keratinized tissue. Posteriorly, it may not be as big of a concern. You may get less recession, but certainly in the anterior, in the aesthetic zone, it's going to be super critical to have thicker tissue. Right? So ultimately, to give us the support for the final restoration. Okay. Thick phenotype, that's what we're looking for. So when we look at the goals of why we want to perform soft tissue augmentation, is to help give us the support, the seal around not just teeth, but teeth and implants. Right? So we have to have that tissue support, because that's also going to give us the bony support around our implants. Ultimately giving us the aesthetic support, giving us the best aesthetics. That's what we're looking for. Nice, harmonious, right? Scalloping soft tissue supporting the final prosthesis, the final crown that gives us the best aesthetic support. So when we look at soft tissue, right, there's differences between implants and teeth. We know that, right? We have to consider, is there similarities and differences? What are the similarities and differences between teeth and implants? We know the differences. We know the role of keratinized tissue, right? You hear the terminology about biologic width, right? Supracrustal attachment, which is what it's known as today, right? Biologic width. If we invade the biologic width, that's going to lead to recession, right? That's basic periodontal 101, right? So understanding the differences between teeth and implants, right? Because we have to look at the connective tissue attachment. The fibers are different between teeth and implants, right? When we look at teeth, those fibers, they run parallel and attached to the root surfaces of the teeth. With implants, we don't have those perpendicular fibers. Teeth, we have the perpendicular fibers. In implants, those fibers run parallel because they don't attach to the titanium surface. And because they don't attach, when we're probing, right, that seal around teeth is going to be different from the seal around implants. And so that's also even been debated between teeth and implants is, do you probe or not probe? And that's been a huge debate in the field of periodontics over the years. Many clinicians will say, well, if you probe your implants, you're disrupting those fibers. So you should not probe. There are other clinicians that say, well, you have to probe so that way you have an indication as to knowing whether or not there's a deep pocket or deep pseudo pocket. How are you going to determine and diagnose the implants properly? And so that was a big debate going back and forth, to probe or not to probe. What do? I probe. I want to have an initial measurement of understanding where my attachment fibers are, how deep am I, right? Taking notes and records of that, so that way as you progress with the case going forward, you moved. We'll start again. Okay. Good morning, everyone. We're starting this presentation again. Oh, thank you. So, to probe or not to probe? I probe. Then there's the other debate too now. What's the best instrument to probe with? Right? Because we have different types of probes. We have titanium probes, we have stainless steel probes, and we have plastic probes. So why would you use one probe versus another? And that's been debated. Some clinicians will tell you, well, if you use a titanium probe or a stainless steel probe, you may damage the surface of the abutments or the implants, right? If you scratch the surface of the abutment or the implant, scratching the surface, what are you doing to the surface of that implant? You're roughening it. You're creating scratches, you're creating irregularities onto the surface of that metal. And so if you do that, you may have more risk of harboring maybe some bacteria attaching to that surface. So that's been debated. So we have plastic probes or titanium probes that will not damage the outer surface of the abutments or the implants. And so that's been debated. But you can see that clearly the differences between teeth and implants with the fibers, connective tissue fibers that run perpendicular and attach to the root surfaces, versus implants where the fibers do not attach perpendicular, they run from the crest of bone running parallel. And that's why we can probe deeper in the implants, which is going to be considered a pseudo pocket, versus probing with teeth. And so because of the attachment, that's where we get the seal around our teeth, providing that seal support around the teeth. We want nice thick tissue that's going to be stable, and even though we probe, it's going to provide some support around the final restoration. Ultimately, it's going to be about the final restoration. And so when do we perform these procedures, right? Now, these procedures can be performed before implant placement. You do your diagnosis and treatment plan, knowing that you have thinner phenotype, then you may recommend, let's do the soft tissue augmentation first, before implant placements. Let's build the foundation, not just the hard tissue foundation, but the soft tissue foundation. So let's do that first. You can do it then, or you can do it together during your implant placement, because maybe you don't want to perform a secondary soft tissue surgery first. You want to do maybe 2 procedures in one, right? Maybe save the patient a little bit of anxiety, right? You want to perform both procedures in one visit, save time and less complications, but may have more risk involved because you're doing 2 separate procedures. So you could do it during implant placement. You could stage it and do it after implant integration, doing it at the uncovery stage. So knowing that after healing, maybe the tissue, the soft tissue phenotype is thinner, then at the uncovery stage, we could perform soft tissue augmentation. Another option is maybe after the restoration, which is probably not the ideal time. After restoration, you realize, oh, the tissue's not thick. You tell the patient, oh, we have to perform a soft tissue procedure. The patient's going to ask you, so why? Well, why didn't we do this earlier? Why didn't we do this sooner? What are you going to tell the patient? Well, we had tissue, it shrunk over time, so why didn't we manage it before that? Or sometimes long-term, patients come back and the tissues shrunk, got thinner, and then maybe it's even after the restoration has been completed, maybe during the maintenance phase, we have to do a secondary procedure. So I actually see a lot more of my patients coming back, more in the posterior quadrants where they have thinner tissue, and I'm seeing recession. When we see the recession, what happens to the bone? Potential more bone loss. That's what happens. And so we want to avoid, if possible, performing these soft tissue augmentations after restoration or even during the maintenance phase. If we could avoid those 2 time frames, that's going to be better for the patient, it's going to be better for you as a clinician, and it's going to be better for the long-term success of the outcome of that implant case. So ideally, if we can perform the procedure either before implant placement or if you want to do it during implant placement, that's probably the best time to perform the soft tissue augmentation. Okay? So this was an article that was published in 2017. It's 2017, it's the suggested protocol for the timing of soft tissue management around dental implants. Okay? It looks a lot more complicated than it is. And so if we follow this flow chart, this gives us an idea in terms of the timing of when's the best option or best timing for soft tissue procedures. So everybody's got their cameras. It's early morning, so, but okay. So the first thing we do is medical dental examination. That's what we all do, right? Medical dental examination. Medical history, dental history, medications, right? So we do the medical dental examination first. Right, that's what we all do in the initial visit. The second criteria now is going to be you develop a prosthetic treatment plan, right? Because everything is prosthetically driven. So before implant surgery, you want to develop a prosthetic treatment plan. Okay, Mr. Lee, you need 5 implants here. If you want, we can give you more or less, whatever, right? But the ultimate goal is you have a prosthetic treatment plan. Once you determine the prosthetic treatment plan, the next question you want to ask yourself is, look at the soft tissue, keratinized tissue. Okay, so do I have enough carious tissue? So medical examination, dental examination, you come up with your prosthetic treatment plan, then determine your soft tissue. How much carious tissue do I have? There's only two answers. Either you have it or you don't have it. Okay? So if you have the tissue, then the next question you have is, okay, I have the tissue, do I have the bone? So that's what you see here. So if you follow the left side of this flow chart, I have carious tissue. The question next is, do I have bone? And again, it's only two answers. Either you have enough bone or you don't have enough bone. If you have enough bone, great. Now you have the bone, you have the tissue. Then you can go ahead and place your implant. So very straightforward. If you have the bone, you have the tissue, then it just follows. You can place your implant. But if you ask yourself, do I have bone, and you don't have bone, now look at, you have a deficiency in bone. Now you have two options. Either it's a minor to moderate defect or it's a large bony defect, right? Two types of bony defects, a small minor bony defect or a large bony defect. If that's the case, if you have a mild to moderate defect, then maybe now you can go ahead, okay, you can still do your implant, but also perform your bone augmentation, your bone graft together with your implant placement. So you can do that. If you're lacking a bone and you have a larger bony defect, now you can maybe want to do your bone graft first because you want to build a foundation, bony foundation, then let it heal, and then place your implant. So you want to stage that procedure maybe. Okay? As you get more experience, more comfortable, some clinicians may prefer to perform both procedures at one visit. You do your implant and bone augmentation. But to take less risk, right? We talked about risk factors, we talked about success and failure. The less risk you take, the more predictable, more successful we're going to be. So to be less risky, then do your bone augmentation first, let it heal, then put your implant in. So very straightforward. Much simpler if we have the tissue, if we have carious tissue. Okay? So now let's look at the left side. In the scenario where we're lacking tissue, we have a deficiency in carious tissue. Again, the next question you ask is, okay, I have a deficiency in tissue, but do I have the bone? And again, either you have the bone or you don't have the bone. Okay? If you have the bone, now you have several options that you can determine which is going to be the best for your patient and what you're comfortable with experience-wise. If you have the bone, then you could do your soft tissue augmentation first. Again, staging it. Do the soft tissue augmentation, let it heal, then go ahead and place your implant. You can do it that way. Or you could go ahead, okay, I want to place the implant first because I want to let that heal, then stage it and wait and place, and then do your soft tissue augmentation. Right? So you can do one or the other, whichever you prefer and whatever procedure you think is going to be best for that patient. The third option you have here is going to be, well, I have the bone, but I'm lacking tissue, so I'm going to perform both procedures together, meaning do the soft tissue augmentation and the implant together at the same visit. So you can do that. So you have three scenarios that you can choose from, provided that you have the bone, but you're only lacking the tissue. So you have options. If we look at the right side of this flow chart, we're lacking tissue and we're lacking bone. Now that's where it gets much more complicated, because look at all the options we have. We have many more different options to choose from. When you're lacking tissue and you're lacking bone. Okay, the mic. I'm like killing everything this morning, huh? The mic, okay, but look at the bottom right. When you're lacking tissue and you're lacking bone, we have many different options to choose from. You can do soft tissue graft first, do the soft tissue graft first, then your bone graft, then your implant. So these are all staged approaches. So the left side, these three scenarios, you can do your soft tissue first, or your bone graft first, right? Then let it heal. Then the second stage, you can do either your bone graft after soft tissue, or your soft tissue after bone graft, or your implant after bone graft. So look at the three options here. Now, as we continue to the right side of this flowchart, there's more options. You can do your soft tissue augmentation first, and then do your implant and bone graft together. Or you could do the implant and bone graft first, and then your soft tissue. So look at how many options you have. Many different scenarios to choose from. But knowing that when we have a deficiency of bone and a deficiency of tissue, it gets much more complicated, because now you have many different options to choose from. What's going to be the best for your patient with that kind of clinical case? What are you comfortable with performing for that particular patient? So it gets much more complicated, much more risk involved, and hence much more thinking that you need to do in terms of planning those cases. And so when we look at soft tissue grafting, if you have the bone and you have the tissue, that's the best scenario, because then you can go ahead and plan your cases pretty efficiently. It's when we have a deficiency in both tissue and bone, then it gets much more complicated. But you can see how everything kind of follows the prerequisite of needing both hard tissue and soft tissue. You can't do one or the other, because a lot of times, more often than not, it's a combination of needing both hard and soft tissue. So when we look at some of the principles of grafting, these are very similar to what we've spoken to about in terms of bone grafting. Blood supply. When you do soft tissue procedures, it's all about blood supply, right? You need graft immobilization, whether it's bone grafting, whether it's implant placement, right? Graft immobilization, implant primary stability. There cannot be any movement, no mobility. Good hemostasis. You want the large donor site to be large enough, and you want adequate thickness of that graft, right? Even when we do bone grafting, you want to add more bone so that you have more better predictability. So how do we gain more keratized tissue? Different ways. You can do apically positioned flaps, we can do free gingival grafts, or you can do connective tissue grafts to increase and improve the soft tissue phenotype, the biotype, right? So some of these procedures, the simplest procedure is probably doing, if you can, an apically positioned flap. Basically, you're just kind of repositioning your incision design, right? We talked yesterday about the importance of incision design. Just by repositioning your incision design can be very strategic in terms of gaining more keratized tissue, right? And so if we look at this case here, just by repositioning the incision will give you the advantage of increasing the volume and amount of keratized tissue. Mucogingival defect, right? There's your mucogingival junction. Right from the palatal view, you can see. Now, palate, this is all keratized tissue. And so, very strategically and very simply, just by making your incision to the palatal, that's going to give you more keratized tissue. Here's your mucogingival defect, right? If we make an incision mid-crestal or even slightly buccal, we're not going to have an adequate zone of keratized tissue. So we want to have more keratized tissue. So make my incision to the palatal, right? Make my incision more to the palatal so I can bring more keratized tissue over to the fascia. Look at the thickness of tissue that I'm able to bring over. I have a wider zone of keratized tissue, but making sure just by simply making an incision to the palatal, you can bring all that keratized tissue over to the fascia. And so just by doing that, now we can go ahead and place our implants. Look at the incision design with respect to where my osteotomies are, where the implant's going to be. To place my fixtures, healing causes one thing, but look at this. This is what we call the Palachi technique, where I have a wide zone, wide band of keratized tissue, nice thick tissue. This Palachi technique is I'm trying to improve some papilla between the two implants. I'm trying to increase the chances of gaining some papilla by doing a pedicle. A pedicle, what's called Palachi technique, taking a pedicle flap and then swinging it over to try and improve and increase papilla between the two implants. That's what we're trying to do by this strategy. So taking a pedicle, swinging it over. We don't detach it. It's not separated, right? It's still connected at the base. So you make an incision, still connected at the base, and you're gonna swing this flap, this pedicle to the center, to the middle, between the two implants, right? So that way we can utilize that tissue to help improve the chances of gaining some papilla between the two implants. That's what we're trying to do with this strategy, right there. You swing that pedicle, swing the pedicle, it's still connected at the base because that's where you're gonna get your blood supply, from the base, right? So that's why you need to make sure to keep it connected. You don't separate it. You take that band of tissue, swing it over, that's gonna help improve you getting some papilla between those two implants. So applique position flap, we're doing an uncovery. This is the second stage. We expose the implants. We go ahead, place our healing abutments, and then we take our pedicle. So I'm taking a pedicle, from this case, from the palatal. So I make an incision here, come across. It's still connected at the base. Make an incision, still connected at the base. We're gonna swing that pedicle between the two implants. Okay? That's what we're doing here. So you swing that tissue, and then you just use some interrupted crisscross sutures just to stabilize the tissue between the two implants. That will help improve the soft tissue between the two healing abutments. You can let it heal secondarily, but many times when we let it heal secondarily, the tissue between the two implants, you get a little depression, right? Because of a deficiency in tissue between the implants. And so I'm trying to increase the thickness of tissue between the two implants by doing this Palachi technique. And then now look at the tissue. Nice, healed, thicker amount of volume of tissue between those two implants. Now we can go ahead and take this to the restorative. Now it's ready for impressions or scan. But look at the amount of keratinized tissue that we're able to gain, right? All good keratinized tissue between the implants. Now you can go ahead and do your impressions or your scans now, and then take this to final restoration, right? But it's really about paying attention to the details. That's what we're looking to do. And so with soft tissue and hard tissue, they have to go hand in hand, together, working in harmony, right? Here's the case. Patient came to the office and said, Dr. Kim, I don't like the way my front tooth looks. I said, neither do I. It doesn't look very good. I mean, that's how she presented. Now, how would you treat this case? What would you do? Not an easy case. But there's choices that you can make. You can treat it however you think is going to be appropriate in terms of what your experience is and what you think is going to be the best scenario for the patient. There's no right or wrong answer. It's going to be what you think is going to be the best for that patient. So this patient, she had this large defect here, right? We can assume a lot of bone loss, certainly a lot of tissue loss, right? We have a lot of loss of attachment there. So are you going to treat the soft tissue first? Or are you going to treat the bone graft first? Or are you going to do both? Right? So that depends on what your comfort level is, how much risk you want to take, but understanding we want to now classify what we're dealing with, right? We have to understand that when you're doing these procedures, the classifications is all going to be part of your diagnosis and treatment plan. And so we're dealing with a Miller Class 4 defect, soft tissue loss, bone loss. Look at the radiograph. There's no bone there. No bone. So how are you going to treat this case? What are you going to do for this patient? You're going to do the soft tissue first, you're going to do the hard tissue first. Or you're going to do both. Then the next question you also have to have is, okay, how am I going to provisionalize? Right? How are you going to provisionalize this patient? It's the central incisor, young female. She was about 28 years old. So what we decided to do is we knew this tooth was going to be removed. So we decided to treat both the tissue, soft tissue and the hard tissue together. So I wanted to combine those procedures into one surgery, so that way I can try to maximize the potential for healing, knowing that I have the option in the future to do another secondary procedure if I needed to. But I'm going to try and maximize as much as I can in one visit to give this patient some type of a result that's going to help improve both the hard and soft tissue. So we went ahead, we made a palatal incision because I'm going to do a connective tissue graft together with a bone graft because there's no keratinized tissue here, right? There's no tissue. We take a pedicle flap from the palatal. This is connective tissue, because I want to improve the soft tissue profile together with the hard tissue. So the buccal, we're going to expose the buccal bone, right? We're going to do a bone augmentation. We're going to do some GBR on the facial of that implant site. We're going to stage this. We're going to do the bone graft and the soft tissue graft first. So here's my bone graft. We're using small particle cancellous. This is the Puros family line. This is a collagen membrane over the bone graft, okay? And then I'm going to take my pedicle and then swing that over my collagen membrane. So I have my bone graft underneath, my collagen membrane, and then I take the connective tissue from the palatal, I swing that over, that's connective tissue here, and then do closure. So I'm not looking to get complete primary closure. I'm not too concerned about not having primary closure because this is all connective tissue. Connective tissue, because of a large soft tissue defect, because of the bony defect, so we're trying to improve and maximize the healing with hard and soft tissue. This is 5 months healing. Look at the improvement of that tissue. Right? I have too much tissue, which is a good problem to have. I'd rather have more than less. Look at the CBCT, we grafted everything here. Right, that's all bone graft. Now, 5 months later, this patient now was going through Invisalign, and then we were able to place an implant with a provisional. So there's my implant, temporary abutment, that's a temporary crown. And while the patient is going through Invisalign, we can continue with the next phase of the treatment. So here's how we started. There's after bone graft with soft tissue augmentation, and then final implant placement with final crown. So that worked out very nicely. Final CBCT, bone on the facial, 3 millimeters, and then final restoration. So the patient's currently doing orthodontic treatment, which is why we have these buttons and the stain. But look at the tissue. Look at how we're able to utilize the temporary to help shape and sculpt the outline of the final restoration. That's what we started with. Then the final restoration. And then she's going to do some veneers, and we're going to replace that temporary provisional. But look at the improvement of tissue that we're able to gain. In this case, combining both the hard and soft tissue with that. So I think I'm running out of time. Thank you for your attention, and I have one more presentation afterwards. We'll continue with graft.